So let me talk about MBL and what matters. I want to acknowledge particularly my friend and collaborator Tate Shanafelt, who's really initiated a lot of these studies and brought them to fruition, but also other collaborators at Mayo Clinic listed here. Also, I want to acknowledge the research support that we've gotten. So the objectives for this talk will be to briefly review the history of MBL, the classification of MBL, certain what I consider important clinical and biologic considerations, and then end up with future challenges. It's a lot to go through, but I hope to do it lucidly for you. So the initial discovery, for those of you who are not aware of this, was it was almost accidental through some CDC studies at environmental health hazard sites where immune monitoring was conducted, and in that study using two-color flow, it was discovered that 0.6% of individuals over the age of 45 actually had clonal B cells. The phenotypic clone was identical to CLL in the majority of individuals. Since that time, the prevalence of MBL has been shown to be much more common than CLL and SLL. Now, in terms of prevalence, subsequent studies have shown that as you age, and depending on the technology that we use, that the MBL percentage will increase to 3% over the age of 40, 5% over the age of 60, and theoretically, if we live long enough, we'll all have MBL. Of course, it does depend to a certain extent on the technology we use and the number of events that are acquired. There is also the interesting issue of familial CLL and also sporadic CLL. For familial CLL, the first-degree blood relatives have a very high prevalence of 13 to 16%. Sporadic CLL, so the familial CLL is two or more blood relatives that have CLL. Sporadic CLL, there are no relatives. In sporadic CLL, the incidence is 16% for blood relatives over the age of 60, and that has important implications in terms of their tendency to develop CLL, something I'll come back to later. It turns out in a landmark study by Ola Landgren that CLL almost always will have evidence for pre-existing MBL. And the landmark study was the New England Journal study where 77,500 healthy adults were studied in the PLCO screening trial. 129 were found to develop CLL. 45 of these had a pre-diagnostic sample with a mean of 32 months prior to their CLL diagnosis. Using six-color flow and IGHV analysis by RT-PCR, it turned out that in the 45 CLL patients, 44 had pre-existent MBL. This was up to 6.5 years before CLL in one case, and one could see both mutated and unmutated IGHV clones in the MBL. So with that as a background, let's turn to classification. Turns out there's three variants. A CLL like MBL where the immunophenotype is CLL. There's an atypical MBL where CD5 is expressed, but now the CD20 is bright, and there's lack of CD23. Here you need to be thinking about lymphoma and excluding mantle in the diagnosis. There's also a CD5 negative or non-CLL MBL. There the CD5 expression is gone. There's obviously still a clonal B cell population, but in this case, we need to be thinking about marginal zone or leukemic mantle cell lymphoma. Suffice it to say that Jerry Marty's paper in 2005 has really been kind of the gold standard in terms of how we think about MBL diagnosis. There should be a circulating population of clonal B cells that have the right phenotype. The total B cell count should be less than 5 times 10 to the 9th per liter, but I'll come back to that in a moment. And there are no other features of lymphoproliferative disorders. Now, within the variant of CLL, there are two MBL types. There's a clinical MBL. This is usually diagnosed in the setting of lymphocytosis. The median concentration of the clonal B cells has been shown to be around 3,000 per microliter, and this is designated as high-count MBL, something I'd like you to remember. The population screening MBL, and many of these studies of population screening MBL have been done by Paulo Guia and his team, are now defined as low-count MBL. This is detected during routine screening of healthy people. There may be as high as 50 clonal cells per microliter, but you can see the very low median absolute count. And this is now designated for purposes of this talk as low-count MBL. So let's turn to clinical and biologic considerations of these two variants. With respect to IGHV repertoire, there are some distinct differences between low and high count. While the somatic hypermutation status is the same, roughly 10% unmutated, the stereotype B-cell receptors are infrequent in the low count, perhaps 5%, and there are different IGHV repertoires in the low count, where the more typical, if you will, IGHV 434 and 323 are underrepresented, and IGHV 169 is really apparently absent. Now, what about FISH status? We and others have looked at this, and this is kind of a representative set of data where low-count MBL clones were shown to display a much more lower frequency of chromosomal alterations, and they're restricted to predominantly 13q and trisomy 12. The high-count MBL, you can see higher risk FISH, including deletion 11q, and more recently, deletion 17p and notch mutations have been found, but only in the high-count and the CLL patient. So what's the natural history of low-count MBL? The group from Italy has shown the way in that area. The natural history is looked at in 76 individuals with low-count MBL. Median age was 66. Median follow-up about 34 months. And you can see here the CLL-like as well as the atypical and CD5 negative. But note that this tends to be persistent. So the solid bar is 90% of the patients who had a mean of 50.6 clonal cells per microliter had a persistent clone, whereas only 10% were transient, and then the other subtypes tended to be more transient. So the clone persisted in most patients. There was no real increase in the B-cell clone. No patient developed clinical leukemia, including 2 patients with deletion 17p13. The etiology of this of the low-count MBL is unclear, but you could postulate that potentially in selected patients with low count, there may be an evolution to high count, potentially through acquisition of high-risk genetic abnormalities, but that's not really known for sure. Now, one aspect that I want to cover for you is whether or not high count is really SLL, and the reason for pointing that out is that isolated lymphadenopathy is a very common pattern of progression. So is high count MBL really misclassified SLL? And there are really 2 studies that suggest that's not the case. So in work, again, from Italy, baseline CT scanning in 584 high-count MBL, only 6.1% had lymphadenopathy by CT or ultrasound. In addition, work by Gentile, where baseline CT scanning was done in 69 patients with high count, while there was more lymphadenopathy by CT, only a small percentage progressed to require treatment, and lymphadenopathy by CT really didn't show any relationship to requiring therapy. Now, in 2005, there was a recommendation that MBL be defined as clonal B cells being less than 5 times 10 to the 9th B cells in 2005. And as you'll recall, the 98-96 criteria for CLL was that clonal B cell phenotype and ALC be greater than 5 times 10 to the 9th. So for a while, there is an overlap in diagnostic criteria. So patients with an ALC greater than 5 times 10 to the 9th, but less than 5 times 10 to the 9th clonal B cells would fit both MBL and CLL. And Tate Shanafelt in our group has looked at how this would look when we use the IWCLL 2008 criteria. You see here, first of all, the overlap between clinical MBL and clinical MBL that was previously CLL using the 96 NCI criteria. When we use the 2008 criteria for CLL, that is 5 times 10 to the 9th B cells, we now see a significant change in that clinical MBL. Previously CLL patients might now become clinical MBL, and in fact, in our own studies, 40% of patients who are classified as RYE0 over a 9-year period were actually reclassified to MBL under the 2008 criteria. We've continued to look at this in work done by Tim Call and Aaron Norman. They've looked at the population in Olmsted County over 10 years, where we identified 123 individuals with CLL phenotype. In the 96 criteria, there are 115 CLL and 8 MBL, but with the 2008 criteria, there are now 79 CLL and 40 MBL, and you can see this figure showing the flip if you will, or not flip, but a significant change in the ratio of CLL to MBL using the new criteria. Now, what does this do? Well, this changes, for one thing, the incidence as we calculate it per 100,000. So you see CLL and high count MBL, the 96 criteria is actually reduced to 6.8 from 10. This is age and sex adjusted. Whereas now for the high count MBL, the 96 criteria go, age and sex adjusted incidence goes from 0.66 to 3.5. Now this has other implications. One of the possibilities here is that natural history of CLL is now altered. And again, in work by Tim and Aaron, which is about to be published in Cancer, this is a look at median time to treatment for the 96 criteria versus the 2008 criteria, where we look at the old definition, if you will, the new definition, in terms of patients who were untreated. And what you see here is now the median time to treatment is gone from 9.2 to 6.5 years, so very dramatic change in the natural history. Additional reasons for looking at the B cell count as a reasonable means to say that you can differentiate between MBL and CLL is the study published by Tate, but also then validated by Scarfo's work, where he looked at untreated patients based on their B cell count. And based on clinically recognizable MBL, RYE0 subdivided into B cell counts of 5 to 10 or B cell counts greater than 10, you can see that the progression rate per year is very different. 1% per year for MBL, 3% per year for patients with CLL between 5 and 10, and then 5% per year for the higher B cell counts for CLL patients where they're over 10. So he postulated that B cell count is the most important predictor of clinical outcome in patients with MBL. To further look at this, we've analyzed lymphocyte thresholds for RYE0, looking at overall survivorship and treatment-free survivorship in a large cohort of 459 patients. And what we have found there is that the absolute lymphocyte count does not reach significant values when using 5 times 10 to the 9th per liter. However, as you go up the B cell count from 5 to 11, you see that the p-value now becomes significant for both treatment-free and overall survivorship. So currently, we're postulating that B cell counts greater than 11 times 10 to the 9th would be confirmed as the best predictor for TFS. And this is even after controlling for other prognostic factors. And again, the two subsequent series from Italy referred to here, each involving greater than 600 patients, were confirmatory of that. So what's the natural history of high count MBL? Again, this is work published by another group, Andy Rostron from the UK. They followed 185 patients with a high count MBL. 28% developed progressive lymphocytosis. 15% subsequently met criteria for CLL after around 7 years. 7% required chemo, and 2% ultimately died of CLL. So the life expectancy for high count MBL is really very different than low count. The survival compared to age and sex matched population is influenced by B cell counts, as I've shown you. Here is in some work that we've done, we've looked at the survivorship for MBL, in this case stratified against, looked at against controls where we stratify for CD38 positivity. MBL as a group does not necessarily differentiate, is not necessarily different between control, but when you stratify for 38, you actually begin to see that CD38 positive, bless you, MBL actually do worse. So there may be biologic features we can use. Ultimately, the prognosis of high count MBL we would suggest is related to the B cell count, is independent of other prognostic markers, and it does belong in the classification schema and supports the use of B cell levels and diagnostic criteria for MBL. Prognostic profile generally for high count tends to be similar to the RYE0s, and most studies now generally suggest markers that predict outcome for CLL will probably predict treatment-free survivorship for high count MBL, and they're listed here for you. Just don't have time to go over all of these in detail. However, the role of prognostic parameters in routine practice is probably debatable given the low rates of progression for high count. What about patient counseling and monitoring? Currently, we're not recommending the use of the term leukemia. It's probably appropriate given low risk of progression, the minimal impact on life expectancy, and you do potentially reduce emotional distress. What we're recommending for our patients is annual follow-up, physical exam, CBC, and paying attention to the absolute lymphocyte count and its level as being a predictor for outcome. We do cite the UK experience, which is a little bit different in terms of how they monitor the high count. The initial evaluation is by a hematologist. Symptoms are evaluated by questionnaire, and usually they then get local phlebotomies done at a central lab, and this basically seems to reduce the burden in the heme clinic and improves patient satisfaction. There are some phenotypes to MBL I'd like to quickly mention. The infection and cancer risk is probably different for a high count MBL. So just as a reminder, we know that CLL patients have significant problems with infections. I don't have to go over that with this group. But the question we asked is, are these risks present in MBL? And we've now found and published that hospitalization for infection is markedly increased for MBL and not very different from CLL. And you see the survivorship for MBL patients in terms of their incidence of infection. There's a really very significant increase in the infection rate for the high count MBL. The risk of infection for CLL and MBL in this study persisted even after adjusting in a multivariable analysis for age, sex, treatment, and comorbid health problems. There's also a recent study published in respect to cancer risk. MBL, in this particular study by Solomon, reported ASH. There's an increased risk of non-hematologic cancers, exclusive of the non-melanoma skin cancers. You can see the increased risk for MBL and CLL patients. And again, the incidence in years since diagnosis for MBL and CLL compared to control. This increased risk persisted again after excluding concurrently diagnosed cases. And again, the risk cancer you see here for the hazard ratios are not too different between high count MBL and CLL, and again persist after adjusting for other variables. So individuals with high count MBL have an increased risk of second cancers and serious infection, and these risks probably we think might be greater than their progression risk to CLL requiring therapy. So in summary, the high count MBL, we believe now the high count MBL, we and others believe that precedes overt CLL. Progression to CLL requiring treatment is approximately 1% per year. The current classification scheme using the B-cell count has clinical relevance. The changes in the MBL-CLL diagnostic criteria of the last 10 years have impact in terms of incidence and natural history. And the high count MBL, we would suggest, has a clinical phenotype. I just mentioned the infection and increased cancer risk. Just to end with the future challenges, I just wanted to mention that one thing we're concerned about is, where do we put high count MBL? Does it really belong with RISE 0, or should some of the RISE 0s now be put into high count MBL? And with respect to the RISE 0 patients with low risk of progression, should they really be perhaps now subsetted with the MBL that have low risk of progression? This potentially would reduce emotional burden. I want to just end up mentioning that the challenges that we face in MBL are not just what I mentioned, they're increasing. And this is a very interesting study reported by Jerry Marty and his group, where individuals who are giving blood transfusions were found to have monoclonal B-cell lymphocytosis. Most of the MBL cases were detected in donor populations that had low count MBL, where obviously there's a little increased risk for progression to a lymphoid malignancy, potentially for the donor. However, we don't know for sure. And a proportion of the donated blood does contain high absolute counts of monoclonal B cells with less indolent phenotypes. So a conservative approach toward blood transfusions may be prudent, and I would suggest that this needs further research and study in order to fully determine the risk factors for progression. I think I'll stop there and thank you for your attention.